Welcome back. I hope you've had a chance to re-energize. It was only a very short chance to re-energize, actually, but we've got lots more content to cover. So let's move on to our last panel of the morning under the heading Digital Communication Tools. Making the shift towards a digitalized system, documents and clinical messages has enabled patient data to be shared much faster and safer between healthcare providers, delivering a better service. Clinicians can safely communicate photographs and test results with one another, as well as quickly discuss patient cases across teams, thanks to digital messaging systems. This in turn has allowed clinicians to work more effectively and efficiently, lowering waiting times in care, spending more time with patients, and seeing more patients through this use of technology. So to help us explore this important and pressing topic, I'm joined by Matt Gauler, Chief Executive Officer, Monaghan, Head of IG Policy, Director of Policy and Strategy, NHSX, Tremaine Richard-Noel, Head of Emerging Technology at Northampton General Hospital, and Dr. Nithin Narayan, Acute Medicine Consultant for Bolton NHS Foundation Trust. So don't forget to submit any questions that you have for our panellists in the live Q&A function on the right-hand side of your screen. So good morning to you. Lovely to see you all this morning. Matt, I'm wondering if we can start the ball rolling with you and ask what the biggest challenges are to having a holistic approach to communication across the ICS.
Morning, Helen, and morning to the rest of the panel. Yeah, I think it's an interesting question, given I guess the focus on the structure now moving to the ICS, and with trying to bring that into trust and into group communication across the system, where everybody's not on the same view of the patient, or they're not sharing the same systems across the whole system. I see that as one of the key challenges, I think, of how we bring and we normalize everything so that we've got one clear sense of truth of what's happening, whether it be from a security perspective of being able to identify who the user is, or from a sort of a care perspective, from who the patient is and who we're discussing, and that seamless transfer between all of the different steps in the services. So I think it's a big challenge, and obviously from our perspective, it's something that really has to be faced up to technology, and how technology can really take hold of that challenge to make the communication flow seamlessly across the system.
And just while we're still with you, Matt, how is staff communication prioritised?
And I think that's another difficult question, and different areas of the system is prioritised in different ways. So whether or not the communication is focused on managing and running the processes within the hospital, which is obviously adding to the overall pressures, and how much time is being given to allow the staff and the overall group to communicate, and to communicate well, rather than just focusing everything on a very sort of regimented task approach to communication. I think it's something that is somewhat overlooked at keeping, especially in these sort of remote times, and trying to bring everybody together, having that free flow of communication between staff and allowing them to sort of share experiences, share workload in an organic way is, again, it's something that I don't believe is being prioritized quite well enough, and it's something that needs to be brought into the digital agenda.
Just wondering, Dawn, whether you agree that it's not being prioritized enough. And I also wanted to sort of talk to you about the fact that data sharing is often considered to be a blocker to change, and why is that, and how can that be managed and improved moving forward?
Yeah, so yes, I would agree that it's not being prioritized, and I get it. I think it's because we're moving through new ways of working. Everybody's trying to kind of feel the way through, and although in terms of ICSs, I guess to those of us that have worked in the field for a long time, we feel like we've kind of been there for some time. It might have had different acronyms as we've gone along, but we've been desperately trying to do this for quite a while. And you know, there's so many different facets. It's so complicated to get it all to be oiled and run as a machine. Then, you know, different things will take priority at different times. I guess in terms of the data sharing, it's, you know, I think most people would agree that either are working in integrated care or have done so over the past many years. You know, the data sharing is imperative. If you've not got the data, you're stuck. You can't really move it forward. It's really important that the data that is shared is quality data and is accurate, and that we're doing it in a timely way. I guess there always has been this concern that, and it kind of alludes back to what Matt was saying in terms of trying to bring different sectors, different organizations together who will all have probably different internal policies, different ways of looking at it, and different risk appetites, which for IG, of course, can cause significant issues if we're not careful. In terms of it being a blocker, you know, those people that have known me a while and have probably heard me speak before, it's not a blocker. There is no blocker to sharing information. The legislation itself is permissive. It isn't a blocker. The blocker becomes when we get this different interpretation or confusion in the system or different policies. So we've got to work really closely together. And this isn't about national dictation of this is the way we'll do it, but it's about working together to make sure that we've got a framework that can operate and that can assist and enable people to have confidence to share the data. That's my view, and that, you know, that's where we're at and where we can help in certainly trying to transform the way IG is thought about and make sure that we're not just focusing on IG professionals, but we're bringing together those multidisciplinary teams of data analysts and IG professionals. And we're really actually focusing on the people that are frontline colleagues that need to have the confidence of what can I do when. And we saw that play out in the pandemic when we focused on the people who actually needed to know pragmatically, what can I do? That worked much better than focusing on professionals and the article this and article that and article the other.
Lovely answer there, Dawn. Nithin, before we move on to the electronic list, which is what I would like to ask you about, do you want to follow on from what Dawn said there about data and add any thoughts to that?
I think, thank you very much for the question. Good morning, everyone. I think data is, I think everyone will agree, data is extremely important. We need to use data to drive practice. One thing that we don't use very well is, as Dawn rightly said, is accurate data. We don't have ways to collect accurate data. And I think one of the things that is going to help us a lot going forward is, as more trusts go towards a digital system of an EPR, we will have access to digital data, accurate data, which we can extract readily and quickly, much quicker than the old days of, you know, getting a set of notes and going through the clinical data to try and find any patterns. And we can be a bit more reactive and a bit more, put a bit more forward planning into these things rather than, you know, be totally reactive once the house is burnt down and we go, oh, there was a pattern there. We noticed that a bit too late now.
Cool. Let's move on, Nithin, to the problems that you were having with the trust and how the electronic list has helped you.
Sure. So I work in, as you said earlier, I work in acute medicine. The issue that we had in acute medicine at Bolton is not too dissimilar to what a lot of organizations in the NHS have within acute medicine, which is the ability to track patients. If you imagine it as a car park, the way Royal Bolton used to work, as we had patients coming in through the front door, we had a list of patients that were referred to acute medicine, which was being stored on a single electronic system within the A&E department. As they moved from one ward to the other, that the patient was moved off that list and put onto a brand new list, and it was difficult for us to track when patients were moving through the hospital. And more importantly, all the lists were being manually updated. So it was heavily reliant on the end users to keep it accurate. So we didn't know where patients were going. We didn't know where they were along their clinical journey, who needs to be seen. There was no transparency as to who were the sick patients. And there was delays in patient care, and we were essentially losing patients within the system, which wasn't great for patient care or even the patient experience.
No, it doesn't sound good to be losing them in the system. And did you find that the list gave you a positive on clinical communication and really improved things for you, so you weren't losing patients in the system, etc.?
Yeah, it's 100%. So the electronic list that we developed in-house was integrated into our EPR, which is Allscripts Sunrise, and it was a contemporaneous single automated system that followed the patient from admission to hospital to discharge, so you could track them all the way through. It integrated into the clinical record, and it updated automatically based on where they were with their clinical journey. So it cut down waiting times for how long patients waited for aspects of clinical care. And it helped us as an on-call team, as an acute medical team, because we were able to use the list to communicate with ourselves. So it reduced the amount of silo working that we were doing, and we worked better as a multidisciplinary team.
Tremaine's been waiting very patiently there. It's always difficult on a panel to get around everybody, especially when you've all got such interesting things to say. Tremaine, accurate data seems to be a problem to collect. Do you find that where you are at Northampton General?
I think it's one of those things that's almost there wherever you are in some respects. So yes and no. So I'm lucky that we run a program with automation, so we can kind of use digital tools in effect to kind of get the information that we need at the right time and help connect up some of those silos of information and make it easier. So I think it's something that I recognize here, in that, you know, you talk to clinicians and sometimes the information is all there in somewhere, but is it in a place that's easy to get, and do you have the right information at the right time? So I think some of that's the big word of digital, because some of it is still on paper, and we're doing a lot of work in Northampton around digitizing our medical records, which will then enable the next sort of phase of moving to digital. And
Tremaine, which processes and departments did you look at first when you were starting that journey to digital?
So we started with, it was quite an interesting one. We started, because it was during COVID, we started with building a bot that helps monitor the oxygen, central oxygen tanks. And that was kind of out of a critical need, which was kind of not where you normally start. So that kicked us off. And then we started looking in, so IT, which is where I'm close to, so that made sense. And looking at things like onboarding. So one of the challenges is often, in a hospital, you need, to pull in additional staff, and those need onboarding. There's constantly change over there, and actually the onboarding process can be quite slow. So we build automations there in HR and IT together to sort of streamline that process, make it easier for clinicians to get started.
Matt, a lot's been said already, so do feel free to add any thoughts that you've been scribbling down while we've been listening to all our other panelists. But what are the drivers and the key areas you think of focus for digital communication?
Well, I just want to say, like, the comments that I think the rest of the panel are bringing out there are hugely relevant. There's a couple of points I think that we've all touched on. And I think it's a term that certainly we use internally here, which is the ability to deliver the right information to the right person at the right time. So I guess it was a little bit of a play on what Tremaine said there as well. But yeah, I think it is about accuracy. So Dawn was talking about accuracy of data and making sure that we are able within the hospital environment to consider all of the different types of communication that's required. So there absolutely is a need for this, what we're talking about now, which is an accurate real-time view of information being sent to people in a structured way. And I think that drives a huge amount of the hospital environment. We do that through, whether it be task lists, whether it be job lists linked to patients, and as they move, being updated and reprioritized. but there's also the need to respect the existing processes that happen in the hospital. So the ability to quite reactively get the attention of somebody, because actually time's of the essence. Rather than preparing data, it's about mustering everybody together at the right time, whether that be alerting them to something so that their attention is made, and really working out, back to that, the right person at the right time, who those right people are. So who's available at the moment, who's got capacity, who can actually take on board more work or more activity. So who can take part in the conversation at this time. And I think that's one of the key challenges, I think, to digitizing communication, is it turns what has always naturally been a very synchronous operation, two people in the same room, to being sort of separated and perhaps asynchronous, where it's essential that we use technology to understand who those people are, what their availability is, and more importantly, what type of interaction is required to get the job done, to get the action that's needed to be done as quickly as possible. And sometimes that is about packaging up an extremely accurate piece of data that's stripped in from different EPR systems, like Nithin said, bringing that accuracy into the information exchange, so that when information is delivered to a clinician, they've got everything that they need to make that decision. There isn't a prolonged exchange needed between people now to find the right information. And I think, coming back to Dawn, it's about establishing that confidence in the data. So whether or not we embed, like you say, we embed frameworks in here to do with our data sharing agreements, but it's about overcoming this trust issue and bringing total confidence into communication, so that when I'm presented with information, I'm confident of being able to act upon it and move the process forward in a very healthy and productive way. So I think that's the key objective of a good communication solution, is to be supportive of all of the different types of communication that are required in the hospital, not just one stream of communication. So,
Matt, it's interesting that you use the word trust. That word has come up a lot today. Dawn, talking about the public, we as patients, as members of the public, are often concerned, aren't we, about privacy and the use of information by private companies, and where is this information we give going? I must admit, I'm always a bit nervous about just putting everything out there. Is that a valid concern, do you think?
Yes, if it's a concern of the public, then it's valid, and we need to address it, and we need to address it through transparency. I mean, I think we're at a stage where we absolutely need to further open up that conversation with the public, and if you like, reset the contract with the public about what we do in the NHS. And I think this is the ideal time to do it, post-pandemic, when actually we're seeing coming through in certain surveys and in anecdotal evidence that while some people have gone the route of, I want to opt out because what's happening to my data, we've seen an awful lot of people who have realised that the sharing of their data can not only have individual benefit, but massive societal benefit. And if we can build on that in building those messages and that right kind of, same as I say, contract with the citizen about what the NHS is and what it does. Because for me, the NHS it's a brand, where it's hundreds of thousands of different organisations, some of which are public, some of which are private. And the way in which we share data, if we're transparent about it, I worked at the ICO before that. I worked in the NHS, and lots of private companies deal with privacy really, really well, because they know that that's one of their unique selling propositions for starters. So you can't take the premise that every public organisation treats your data really well and every private one is there to make profit off data and is going to treat it really badly, because that's just, it's not realistic. That's not the world that we live in, but sometimes that's the perception. And it's about getting over that in the NHS, we are public and private partners and we trust one another and we've got confidence in that we do the right thing at the right time, but that we don't, as the NHS, just sell data willy-nilly to whoever for profit. That absolutely doesn't happen, but we need to get that message across. So it is all about transparency, but I would like to just touch on what Matt said about purpose, really, in terms of when we're using data, because we have so often at the moment got ourselves into this position where, because of the common law duty of confidence that we're obliged to meet when we're using health and care data, we get really hooked up on, if it's for direct care, it's really easy and we use this implied consent concept. But if it's not for direct care, then we've got to satisfy that confidentiality. And that means getting patient consent or public interest where the bar's very high, or we've got to go for Secretary of State approval to use this data for planning purposes or management purposes. I'm really hopeful that in the amendments to the Health and Social Care Act that we'll be able to broaden that definition properly, because when hearing what Matt said and actually the other two contributors have said, what they've been saying to me, that data has a direct impact on patient care. You know, if we can't get the right people in the right time at the right place, that will have an impact on direct care. And so saying it's planning information, yes, it is, but it does have this direct impact. I mean, really interested to know about the electronic data that's tracking patients around a hospital. I mean, I had, one of the reasons I went into the NHS was that I had a horrible experience 10 years ago when my father was in hospital and we got a call to say we needed to attend immediately because he was going downhill very fast. We arrived there and my mother went to the ward that he'd been on the night before and he wasn't there. And we got sent to the 4th floor and he wasn't there. And then we got sent to the 2nd floor and he wasn't there. And it took us 40 minutes, by which time my father had passed away.
Oh, yeah.
And that was one of the reasons that drove me to join the NHS, that I just felt it was a data issue that had caused that, you know, that problem to occur. So really, really keen that, you know, we are starting to see things coming through now where we're not saying we can't do that because of this. We're just getting on with it and doing it.
Yeah, what an awful experience to go through, Dawn. That's really sad to hear. Nithin, following on from what Dawn's saying and the example she's given there, do you feel that we do have to, as we're embracing new technologies, reset the trust, if you like, with patients?
Most definitely. I think we need to prove to patients that we are putting measures in place that will nullify the experiences, the extremely appalling experience that Dawn went through. And I'm sure, you know, sadly, Dawn, you won't be the only person that's gone through that. And I remember the days of, you know, before we went on to EPR, not being able to find patients, you know, because they've been moved multiple times. And, you know, you had to ring around wards and see if patients were there because there wasn't an electronic bed management system. And this is, you know, this is going back not long ago, you know, 5-10 years ago. Not every hospital has an electronic bed management system. And you had to literally ring around and go, is this patient on this ward? And you turn up and it's a patient with a similar name, but it's not the patient you're looking for. And then you have to go around and and all these things are bad experiences. And unfortunately, people remember bad experiences much better than they remember the things when they go well.
I remember losing my dad, actually, not losing him, he's still alive, thank goodness, but ringing Grimsby Hospital to find out how he was doing, and they couldn't find him, and I got routed through Scunthorpe, and it was a nurse in Scunthorpe that helped me find him in Grimsby, which was quite bizarre. Nithin, you know, how have the changes that you've brought in impacted the way, not only that you deliver care, but also patient care? I do love examples, and I think you're really well placed to give us examples of, positive things that have been happening in Bolton.
So I think it's a multi-factor and multi-level kind of impact. In a direct impact to patient care at the point of care that we deliver in acute medicine, the amount of time that patients wait has reduced significantly. The time that they used to wait for a consultant review has come down by almost a third, so 30-odd%. The rate of movement from the accident emergency department to medical wards has improved. In terms of further downstream, there's plenty of evidence that says there's early senior consultant input has a knock-on effect on patient care in a positive way. So we've had improvements in patient mortality. We've had improvements in length of stay to the point where patients are spending 20% less time in hospital and are actually managed to get out of hospital sooner, which is better for patient care and better for outcomes as well. Those are the kind of key things that we've noticed for patients. And I think the hardest thing as a patient in hospital is the amount of time you wait. The amount of time you wait between clinical interactions and the impact that we've had, especially with the one of the main reasons I put this in place was the lost patients, because I was anecdotally seeing a huge proportion of patients, huge in the sense that I consider more than one a huge proportion of patients that were being transferred to the ward without being seen, and sometimes patients, nursing staff aren't aware they need to be seen by a doctor, and they're sat there through the night waiting for a doctor to see them. And I didn't think that was acceptable. So one of the key things that we've impacted is we've stopped that from happening. The amount of time that patients waited once they moved has come down by almost 50%. And I think that is the biggest impact that we've made. We've also improved performance on the weekends when, as all hospitals in the NHS are, go down to a skeleton staff. So, this is something that's pretty well documented. There are declines in clinical performance over weekends, and that's something that we helped improve. It came in, we implemented this system about a year ago now in November last year, just in the middle of our third wave of COVID within Bolton, just before we had the big wave over the winter. And one of the feedbacks I got from the consultants is it significantly helped in managing COVID patients, because majority of COVID patients come into the A&E department and they go straight to the COVID ward, bypassing the acute medical unit, which is where majority of our workforce is based over a weekend. So consultants were able to see where the COVID patients are, when they've been admitted, and who needs to be reviewed urgently, because these are the new patients that come into hospital.
It's funny, isn't it? Because illness doesn't distinguish between a weekday and a weekend. I had that similar situation in the accident and emergency with my little boy the other day. He needed antibiotics that were locked in a pharmacy that's only open Monday to Friday. And I was like, it just seemed crazy to me that there's any distinction really between any time of day or night, Monday to Sunday, really. Tremaine, it's interesting there listening to some of Nithin's examples. I just wondered what you found have been what things have had the biggest impact where you are. Can you share, any more examples as Nithin has done there?
I think in a probably less detail in some respects. So, we've done quite a bit of different pieces of automation work, but I think some of the things we've seen have big impacts are really on, supporting getting clinicians the right information at the right time. And one of the big ones looking at data is helping with, so in the back end, there's loads of people that sort of sit there and make sure that the systems are as accurate as they can possibly be. So in our hospital, there's a team that merge patient records. So, there's lots of different, so on pathology, you'll get lots of different blood results being sent from, and occasionally the name will be slightly involved, might have a middle name where you didn't on the patient, and there's someone just sitting there doing that. And we built an automation that means that that's done quicker, because automation doesn't need to sleep, and it's done accurately. And I think, that accurate piece is really, really important, as Dawn was saying earlier. And also, I think that something that's slightly off topic, but going back to what we talked about and Donna said around data, one of the interesting things around data in the NHS, there's a big piece around what do we do with the data that we hold and how can we make better use of that for patient care. But there's another piece, which is that's data out, but there's this whole world of data in. So we all wear, I say all, but lots of people are wearing different devices on them that track information. There's lots of stuff on, movement on phones. And actually, I've heard stories of people using Apple Watches and coming up abnormal heart rhythm. They're going to A&E where they may not have, and turned out they had something quite serious wrong with them. So I think there's a whole, for me, it's really interesting to see how data that sort of helps. And actually, as we're dealing with trying to recover from COVID, that tracking and supporting people in the community is going to be really important. And actually, interestingly, that kind of links back to the digital communication where we look at going forward, where there is all of that wealth of data. How do you know when a patient needs, who looks at all of that comes in? How is that monitored? How are clinicians alerted to time, I think, to be in the NHS for big data and that side of things.
And Tremaine, can automations be used sometimes to make clinical decisions?
So not for so I'll give you an example. It's not used for clinical decisions, but what it can do is make it easier for clinicians and quicker to make those decisions. So what we've looking at here right now actually is when a referral comes in from the GP, and there are tens of millions of those a year across the NHS, it takes time to review those, and logging into the system and looking through the list, it can be quite cumbersome. So we're building automation that helps pull that to the clinician quicker, enable them to interact on a slightly different user interface. It's pulling the right information from the patient record and other bits, so they can speed up their decision. And if you think about it, if that takes 1 minute less per referral, that's millions of hours and saved across the wider NHS. So it's quite interesting how this can have a massive impact.
That's wonderful to see, actually, Tremaine. You can see in your eyes and your whole body language how excited you are about all of this. Matthew, I know you'll have feedback because you've been diligently writing notes on everything that's been said. But just when we were talking about Apple Watches and staff and things like that, I just wonder, how reliant is the NHS on mobile communication, and do trusts provide mobile devices, etc., for the staff, or are we relying on staff to use whatever devices they have?
Yeah, I think it's another one of those slight challenges, I think, in terms of the adoption, the full adoption of in-pocket communication, I think is the best way to put it. We hear lots of stories about clinicians not wanting to carry lots of different communication devices around, sort of consolidate to one. But it does come back, I think, as we keep talking about, so Dawn keeps picking up, it comes back to the trust and, how responsible are the NHS being about using my own personal equipment? And do I trust my employer at the end of the day to have information that they're picking up from my phone? It's that whole trust thing. And again, I think we need to re-establish that contract, not only between the NHS and the patient, but also the NHS and the workforce. The workforce being, integral to feeling like they are understood, they're valued, and that they have full trust in the data that's being collected about them, whether it be behavioral data, whether it being about their availability. There's all of this concern that if I adopt if I embrace digital communication, does that mean I'm going to be contacted when I'm in the cinema with my friends? Well, no, it doesn't. But it's building that trust back in, that as a system, we will appropriately use both the data and the resources to get the best possible outcomes at all times. It is about respecting every single person in the system and using everything in the most appropriate way. So I would love to say that, the right way is for everybody to adopt this and to use their own personal equipment, because it alleviates sort of some of the financial burden on the NHS to provide new equipment. But before that's actually embraced, we all use our own applications on our phones to do our banking, to do our children's schoolwork. We trust that. We need to get the workforce of the NHS to also trust that we're using their time respectfully as well. There's just one thing that I wanted to pick up as well. When you talked about the watch, you start to then talk about more population health and inclusion of more people across the system. I think we've had a great debate here, very focused on the acute sector, but I think embracing good communication allows us to expand it beyond the acute into how do we prevent admission in the first place? How do we triage admission? So yes, we can make massive efficiency gains within the acute setting, but I think we can also make massive savings on prevention and, better signposting from primary into secondary, but then also, acute back into the community to prevent readmissions. I think the communication opportunity we've got here to go across the system, once we've got it right in the acute setting, is huge. But again, it's underpinned by the same things: data, trust, accuracy, and effectively the workforce being part of this process.
Before I move on to Dawn, because I'd like your thoughts on that, Dawn, the preventative side. It's something we touched on in our last panel, rather than just dealing with, as Matt said, acute care, the advantages how we could use digital for preventative medicine. But Max has just said, how do you balance the advantages of BYOD with is that bring your own device? You lose a lot of acronyms in the healthcare sector, which is a nightmare for a general news journalist like me. But how do you balance that with the need for resilience within a hospital communication system, e.g. loss, lack of charging, not even owning a smart device? I think that's a really good question from Max. I don't know, Matt, whether you want to answer that.
Yeah, I think it's a great question, and one, again, that is underpinned by everything I've said in terms of trust and everything else. Absolutely, where digital devices are being used for the most critical of services, crash, bleed replacements, etc. There is a duty of care. There's a duty of care of making sure that the right equipment is also being used at all times. And I think in certain settings, there is a need. There is a need for the trust to be responsible about the equipment and balancing that dependency on a bring your own device policy versus actually providing the right equipment for the right task. But I do think there isn't a one size fits all here. There are certain roles, there are certain types of interaction where absolutely a bring your own device, where security is fully understood, where we are able to responsibly take care of the user. But the trust always has to be conscious and have a plan B for those situations of inclusivity where somebody might not choose, for personal reasons, to have the most up-to-date device, or in those instances where I turn up one day and I haven't got some charger, I've forgotten my phone, the ability to have those tech bars where somebody can turn up and pick up a device, a rental device for the day, or loan something out in order for them to facilitate their role, is something that has to be built into every single digital adoption where there's a dependency on new equipment.
Absolutely. Dawn, let's just move on to data and preventative care, really, and how we can embrace it and help avoid the need for acute treatment in some cases.
Yes. So, I mean, we're back really to confidence and to trust, but also to purpose. So purpose is king when you're dealing with data, and you've got to be very specific about what that purpose is. So you can't be transparent if you're just saying, oh, we're going to use this data for population health management, because people are going to go, what's that mean? Because even within the system, you'll have people say, well, there's parts of population health management that are direct care, and they are, and like we talked about before. So you've got to be very specific about when you're saying preventative medicine and population health management, what are we talking? And how specific are we going to be about that purpose? And how do we make that transparent to the citizen about this is what it's about? And therefore they are either comfortable that we do it and have an expectation, but again, about resetting that contract, an expectation that we use information for that purpose, for us as an individual and for society as a whole. Or if you're straying out of that, whether you're giving them the choice about whether or not they want to take part in that preventative medicine. Because I'm sure lots of society, if it's around the purpose of, well, we want to know where to put our resource and where it's best placed. And we know that within this geographic area, they're really screaming out for smoking clinics. And we want to push that, and we want to put the resource in. But over here in Winslow, they don't really need that. They need elder services or whatever. That's fine. But people get very nervous if they think what's going to happen is that they've allowed somebody to suck their data from their Apple Watch or wherever it is, and they're going to look at it and then ring them on a Friday night and say, so actually, how many bottles of wine have you got in the fridge? So it's about that purpose and about being transparent, I think.
Oh, I hope they won't be doing that to me. And Nithin, I was going to ask you about any new tools in the pipeline, or I am going to ask you, that are going to support seamless workflows. But I'd like to blend that, if I may, with Annie's question. She says she totally agrees with the panel that we need to ensure that across our respective systems, we have a good flow of information that's needed to provide right care in the right place at the right time by the right clinicians. What key ingredients do you believe we need to deliver a successful patient passport / communication system that engages staff and patients across the organisation and communities to ensure a seamless transfer of clinical information to reduce hospital admissions and keep people at home? Does that sort of weave into that sort of question about seamless workflows, Nithin, for you?
Yes and no.
I'll take the yes bits of that.
So I think in terms of where we are going next in Bolton, I think I'm riding the culture of change that I've managed to instill within the organisation amongst the staff and amongst the executive team. I think the hardest thing when I first started getting things going was to try and get them to appreciate that we needed to change how we're working. Far too much the NHS tends to respond around, this is how it's always been done. It's a common theme that kind of comes across multiple organizations. So now that we've implemented one system and we've shown that it's working, I'm kind of riding that wave. We've just gone live with our medical e-handover system to try and improve communication within the team, to try and improve patients getting 24-hour continuous care. The one thing that you mentioned earlier is that care doesn't believe in weekdays and weekends, and we're trying to provide better and safer 24-hour care. The other thing that we are looking into at the moment is we're looking into a discharge list, if you will, to try and improve patient flow within the hospital, and encourage and support teams to get patients out of hospital sooner, thereby having a knock-on effect and reducing the pressure at the front end, which is what everyone's talking about at the moment, which is the pressure on A&E departments and the pressure on ambulances and things like that. Now, sorry, what was the question again?
Well, Annie was saying that she agrees with, that we need to ensure across the systems we've got a good flow of information to make sure that patients get the right treatment at the right time by the right clinicians. But she's asking for a successful patient passport or a communication system that engages staff and patients across the organisation and communities to ensure a seamless transfer of that clinical information to reduce admissions and keep people at home.
100%, and I agree with Annie 100%. I think the key thing that needs to happen is we need to have better communication between primary care and secondary care. And we need to recognize that they are not separate events. They are a contemporaneous event. One leads on to the other, one affects the other. And I think that's one thing that happens that definitely organizations need to work on. When patients get discharged, the team in primary care need to know what's happened to that patient, what needs to be done to continue that care. In the same way that majority of patients they admitted into as an acute admission in hospital, majority of them have already seen their GP multiple times or seen services within the community. It could be the community pharmacist, it could be the community midwives, it could be the district nursing team, and they have already potentially had care for the same thing that we're seeing them about. And unfortunately, there is no communication between the teams, and a lot of the time we end up repeating things that have already been done. And if we had better communication between the systems within the community and in hospital, we wouldn't necessarily be repeating things, and we'd be more contemporaneous with our clinical care.
We are almost out of time. I have to say that having done a number of these conferences about the NHS, I think the NHS is moving very swiftly, and it's been a very positive experience. I think technology has been embraced in a very good way. Yes, we've seen some sort of holes in the system, but I've been really impressed from my personal experience how it's moved on. Tremaine, I just wanted to ask you whether you saw that an opportunity here to support the NHS ESG and sustainability agenda.
Yes, I think sustainability is a big one, and it kind of goes hand in hand with digital. So the more you digitize, the less wasteful we are with resources. And I think actually something that's quite interesting is around. I saw a carbon footprint calculator the other day for emails, which was quite interesting because
really,
and you think of cutting so you think of cutting carbon footprint with paper, but actually servers and everything that run these systems also use carbon. So it's an interesting one about sort of in this area, which is why using simpler communication tools, not just sending emails for everything, is actually useful for the environment, which is something that blew my mind a little bit.
Gosh, we don't even think of emails, as I wouldn't think of that in my carbon footprint at all. Matt, we're drawing to a close, but one thing we've not really touched on as much as I'd like to, perhaps, is patients, and how important, is it that the patient be in communication related to their care?
I think Annie sort of raised the question there, didn't she? Where how do we get that successful, and again, I'm seem to be using the same sort of words, but that contract between the provider and the patient, and how do we make sure that there is that trusted flow of information between the patient and the provider, whether it be the primary or acute, essentially the whole system. I think it's massively important that the patient is one of the participants in their own care. I mean, knowledge drives responsibility. So, I mean, somebody being a little bit more knowledgeable about what their care pathway might look like, what they can do to improve their care, what they can do to reduce their likelihood of admission. How can they take better use of the services around the whole system? You can only do that if the patient is involved. And I think bringing the patient into the conversation, into their care, is absolutely essential. But it comes back to the same questions, the same things we talked about all the way today. It's about data, trust, contract. Everything that we've talked about needs to be applied to every single step of this process to make sure that we are accurate, trusted. As soon as accuracy and trust is lost, people drop out of the contract. And if we lose people from the contract, it's not complete, and therefore we can't offer total efficiencies across the system. So that's my view of bringing the patient in.
Okay, so the absolute final word to Dawn. Dawn, do you think that's the case? I mean, clearly we mustn't lose the patient in all this, must we?
No, absolutely not. And one way of keeping the patients on side is them having access to their own information. And, you know, we see that in primary care in terms of GP records at the moment, where, you know, many people can get access to quite a lot of their information on their record. But people think their medical record is that, and of course it's not. Their medical record is much bigger than what is just at their GPs, and they don't get access to the majority of that at the minute. If they could, they probably, accuracy might be helped, because they might know, oh, I've not updated, just for instance, I've not updated my address. You know, so the more we can get people to sign up to that access to their record through the app, the better. The more we can start to nudge forward on the record being a bigger record than just GP, the better. And then hopefully we can get people to donate data then as well, to help us with population health management and with research.
I think you're absolutely right. And I think the other thing that would do is build trust as well. I think if we had access to our own records like that, we could check whether they're accurate. I think it would build trust, and then perhaps make people more giving and wanting their records to be whole, because I don't know, I think there's a lot about patient empowerment here, and feeling sort of, you know, part of your own sort of destiny with medical care. Our panel kept getting extended and extended, I noticed on the time, and I think that's because we, you know, had such a good conversation. So I'd like to thank all of you, my panelists, on our third debate for a fantastic discussion. And it's encouraging to see just how much work's going into digital communication tools, and hear some examples. So thank you for that. Right now, it's time to break for lunch and a true chance to unwind. If you get time, jump into the meeting hub and continue to gain connections and build your community with your fellow delegates, or chat further perhaps to those you've already met. I hope our three panels this morning have given you food for thought, and also topics to break the ice. The connections you build now are there for you to use into the future, logging in at your leisure and exchanging views with not just the delegates here today, but future registrants too, building your community. Our speakers can offer you plenty of knowledge, but a significant source of knowledge on our platform comes from each and every one of you. So do feel free to share your insights too. Let's meet back at 2 o'clock for our afternoon session and our next panel discussion. I look forward to you joining me then.